Great.
All right, well, we're ready whenever you are.
Okay, Jill, do you have anything to announce?
Just wanted to thank you, Dr. Oldani, for coordinating this for UB today. We very much appreciate the effort that you've put into it, bringing in your collaborators and colleagues from past. This, as many of you on the call may know, it's part of an R21 series that Dr. Stu Clark, has been organizing here at the University at Buffalo on really critical topics when it comes to pain stewardship. So thank you, Dr. Oldani, and I will hand everything off to you to lead today.
That's great. Thank you, Jill. I'm really happy to present this pain stewardship team from the Medical College of Wisconsin and Froedtert Hospital. I got to know the team when they presented at Concordia University School of Pharmacy, and it really resonated with our students and faculty about the kind of care they were giving complex patients. And as the newish director of interprofessional practice here at the University at Buffalo, I've been here about a year. And having seen the kind of presentations and interest in the entire, I would say, pathway of opioids in pain management, from discovery through some of our bench scientists and that kind of work, to our education, and then, of course, to putting into practice in the clinical setting, I thought this pain stewardship group would be really applicable. I'm going to let them introduce themselves as they present. I will just give Bill's program a plug in that they have a pharmacy residency that he might mention that's in this pain stewardship area. So I'm going to hand it off to your team, and thank you again for joining us.
All right, well, thank you so much, Dr. Oldani. It's a pleasure to be here and to reconnect with you and your team. We're excited to kind of share some of the work that we do. Today, we're going to talk about pain stewardship and opioid use disorder and how to manage those patients. Quick outline, we'll go through some introductions. We're going to talk about what it means to be a steward. We're going to go through a little bit of clinical content and talk about what we do with respect to direct patient care on a daily basis. And then if we have time, we'll get into a little bit of research and maybe training that happens after school, after pharmacy school or medical school, and what residency options are out there. So first, my name is Bill Froedtert. I'm a pharmacist by training. I spent about 16 years in the trauma surgical intensive care unit before transitioning to pain. That was a pretty seamless transition given that population that we care for. I'm also the chair of pharmacy research, so I help coordinate a lot of those efforts at our organization. And I also have a faculty appointment in the Department of Surgery, Division of Trauma and Critical Care. So that kind of keeps me tethered to the day-to-day practice in critical care. My typical day is divided in many different ways. I don't know if I have a typical day or a typical week. My role really cycles on quarterly, monthly, weekly, and daily cadences, depending upon which hat that I'm wearing. I wear a lot of different hats. I'd like to introduce a couple of my colleagues that I work with when it comes to direct patient care. We have a pain consult service that I round with twice a week. I'm going to go ahead and turn it over to Dr. Kirchen and then Lisa Elliott, a couple of our colleagues, if they could go ahead and introduce themselves and share a little bit about what they do with respect to pain management. And then I'll circle back and provide a high-level overview of what stewardship is. Dr. Kirchen?
Yeah, thank you, Bill. Like Bill said, I am a pain medicine physician. I am an anesthesiologist as my first training, and then pursued fellowship training in pain medicine. I am now the director of our pain medicine fellowship, where we graduate 4 pain physicians every year. It is a 1-year fellowship that is multidisciplinary, so they can come to this training by way of neurology, family medicine, emergency medicine, although most commonly anesthesiology or physical medicine and rehabilitation. I practice pain medicine both outpatient in the ambulatory setting and on the inpatient service. I'm the physician on service maybe 1 out of every 6 or 7 weeks. And then I also work in collaboration with Bill. We are co-chairs of the Pain Stewardship Committee, and so work on a lot of quality projects throughout the institution with him in that regard as well. So we overlap in clinical care and in some of our leadership roles. And then Lisa.
Thank you. Hi, I'm Lisa Elliott. I'm the nurse practitioner on the CHIPS inpatient pain service. I've worked at Froedtert for about 15 years, first as a nurse in various roles, including post-surgical, ICU. I've been working as a nurse practitioner in pain management for the last, 6 years, initially working in the pain clinic and then transitioning to the inpatient setting exclusively. So I work with Bill and with the different physicians as they rotate through our service, but I'm kind of the person who's here on the service all the time. So I work Monday through Friday here on the inpatient pain service.
Awesome. Well, thank you so much, and welcome both of you. Thank you for joining us today. So getting into pain stewardship, a lot of times in the biomedical literature, if you were to do a lit search, you're going to come across the term opioid stewardship more commonly. Opioid stewardship is a little bit more narrowly focused on what the name suggests, opioids, whereas pain stewardship is a little bit more comprehensive and holistic. So it really takes into account not just the use of opioids, but the use of multimodal therapy, looking at non-pharmacologic interventions, surgical interventions, looking at clinical outcomes, regulatory compliance. It's much broader than opioid stewardship. For purposes of the discussion today, though, I think we can use them relatively interchangeably because really the stewardship component between the two has much, much more in common than the subtle difference between opioid and pain. So a formal working definition is a coordinated effort to ensure safe and rational opioid prescribing to produce clinical benefits and mitigate preventable adverse events. And I really emphasize that it's a coordinated effort. None of this work really happens in silos. There's a lot of different individuals that have different backgrounds, different trainings, different degrees, different perspectives that come together to try to look at a given situation through a different lens. And if you can facilitate a collaborative environment where there's a free exchange of ideas, really we found that that's the most robust. When you look at the biomedical literature and you look at interdisciplinary care or multidisciplinary care, especially in the critical care setting, there's overwhelming evidence that patient-centered clinical outcomes are improved when you have a multidisciplinary collaborative environment in which you practice and provide care for patients. So when we think about our stewardship role, we think about regulatory standards, obviously, practice guidelines, those could be national guidelines, those could be institutional guidelines, local resources and local and regional epidemiologic data. Depending upon the environment that you practice, you're going to be at a different starting point. Depending upon the part of the country that you're practicing in, you're going to have different exposures and different baseline data with respect to opioid use disorder, opioid overdoses, things of that nature. We know that there are regional trends, and therefore how one prioritizes as a steward on what to focus on is in part driven by those variables. So I asked my 11-year-old, at the time 11-year-old daughter to kind of put into picture what daddy does for his job. And I kind of explained to her over the course of a couple of years what I do and some of the different things that I focus on and the different people that I work with. And this is the thing that she kind of picked up on. And if you read the caption of the gal there, it says, "Don't worry, I'm sure all the teams are talking to each other." And you clearly have, 6 distinct silos that are in no way, shape, or form communicating with one another. And that's really what I feel like my primary role is as stewardship coordinator. I'm probably not going to be the smartest person in the room. I'm probably not going to be the most experienced person in the room. I'm probably not going to be the strongest content expert in the room. But what I can bring the room in general is the 10,000-foot view perspective. I can help coordinate activities. I can bring people together. When I first took this role, I was amazed how many amazing individuals that I worked with that were doing just tremendous work, patient-centric work in their own area. I was equally amazed with how little they were communicating with other parts of even their department in some instances. Psychiatry does tremendous work with opioid use disorder, but the inpatient and ambulatory practices are very fractionated. It's not necessarily through fault of their own, but we have not provided a superstructure or an infrastructure to facilitate that communication, to bring those groups together. Pain management, palliative care, psychiatry, substance use, all of those in some way, shape, or form are related, but there really wasn't a good mechanism at our organization to kind of bring all those groups together. So really, I feel like as a stewardship coordinator, we're kind of the conductor of the orchestra. We're steering the ship. We're the captain. We're trying to bring all those content experts, all those experts that know everything about anything, and they're looking through the problem through one lens, and we're trying to bring them together with other individuals that have complementary perspective, complementary expertise, complementary knowledge, and try to bring them together and build that multidisciplinary team. So I would encourage all of you as an active learning exercise, and we don't necessarily have to do this now. You can go through it on your own time, but just reflect back on your current practice environment, whether you're clinical, whether you're academic, whether you're administrative, and just think, think about the silos that surround you, and what could you do to kind of bring those silos together and get everybody talking with one another. Now, when we look at our pain stewardship committee that Dr. Kirchen and I co-chair, we obviously have a mission statement, a charter, and a mission statement that goes with it. And I just teased out a couple of what I think are relevant elements of that charter statement. So it's to direct and optimize pain management efforts, and we do that through all environments of care across our enterprise and our organization. So we're right off the bat, we're saying, hey, we're not focused on inpatient, we're not focused on ambulatory, we're not focused on tolerant and naive opioid patients. We're really going to include everybody and anybody in all aspects of care in every corner of our organization in our health system. The second bullet, through a collaborative, I emphasize collaborative, systematic approach to identify, evaluate, mitigate risk, and prevent pain-related adverse events. That sentence is a run-on and goes on and on for a few more lines, but I think you get the gist. And then to improve patient safety. So now, how do we do this? We define what we want to do, but how do you execute that plan? Well, this is what our stewardship umbrella looks like. By no means is it all-inclusive, and by no means should it reflect or represent stewardship programs across the nation, but based on our local epidemiologic data, based on our strengths and our deficiencies, and based on the resources that we have at our organization and what's achievable and which has the greatest return on investment, these are the areas where we've chosen to invest and where we've tried to move the needle. Again, your umbrella might look a little bit different, but in general, I think these are some of the themes that when, again, you go back to the biomedical literature and you look at the science behind stewardship, more specifically opioid or pain stewardship, these are the elements that are going to consistently pop up. We could go on and on about what stewardship means. The National Quality Partners has a pain stewardship, an opioid stewardship playbook that was published in 2018. It's divided into 7 domains, and each one of those domains is divided into half a dozen different sections. There's a lot of elements that go into a stewardship program. It's a very structured process. What we try to do is we try to cater to the audience that we have, and we're really going to just try to focus on a couple elements of our stewardship campaign in a hope that it resonates with your audience. So now we're going to shift a little bit away from some of the lofty mission statements and some of the regulatory compliance and some of the education. We're really going to focus on some of the direct patient care, because at the end of the day, we're mostly focused on patient-centric outcomes. And we know that having an interdisciplinary or a multidisciplinary team improves those patient-centric outcomes. It can be particularly influential in those patient populations that are really challenging to care for. And I think we would agree that one of the most challenging patients that we can see on our pain service is the patient where not only are we dealing with pain, and that pain can be acute pain, it can be chronic pain, it can be acute on chronic pain, it can be nociceptive pain, nociplastic pain, neuropathic pain, some combination of the three. But when you take all those pain dynamics and it overlaps with opioid use disorder, and opioid use disorder has many different flavors. It can be treated, it can be untreated, it can be minor, it can be severe, depending upon the resources that the patient has available to them, dictates the complexity of the care, or more so the transitions of care. So really that intersection, that combination of comorbidities of diagnoses is really, really complicated. And in our collective experience, this is really where we've brought some of the thought leaders together from our organization, and we lean on different expertise. There are risks with undertreating acute pain. There's risks with undertreating opioid use disorder. It gets very complicated and very messy very quickly. If you think about these terms, opioids and opioid use disorder, that's stigmatizing language, right? You don't have to dig very far into the biomedical literature to really get into the science behind stigmatization. Stigmas are real, and that is one of the first barriers that is put up when we're trying to manage these patients. So we really need to be kind of objective and think about that. And with stigma comes lots of misconceptions. And there are many myths and misconceptions that we routinely find ourselves battling to try to provide optimal care to these patients. So I think during the course of this clinical discussion, this multidisciplinary clinical discussion, we're going to get into the details of some of that. So with that, we do have a patient case, and I'm going to go ahead and turn it over to Dr. Kirchen and let her facilitate some of the clinical discussion and let her make some teaching points and call on us when she'd like us to chime in. Dr. Kirchen?
Yeah, thank you for that. So a case that we're going to bring to the group to kind of facilitate a little bit of discussion of how we would manage this at our institution. This is a very common type of patient that we see. We're a level 1 trauma center. So a 31-year-old male who's polytrauma. So he presents to the trauma service after an MVC going at highway speed, found hours later with a prolonged extrication. So a complicated patient, probably with a variety of complicated medical things going on, but of course has many reasons for pain, and that's why they would ask our team to be involved. What makes it especially challenging in this case is this gentleman has chronic daily heroin use to a fairly decent degree. And as I said, he's a polytrauma patient. So he has a leg fracture, frostbite because of this prolonged extrication, rib fractures, and a splenic laceration. So he is now post-op from emergent orthopedic surgery and a splenectomy and has been admitted to the ICU for observation postoperatively. The patient is emerging from anesthesia and beginning to complain of pain. So when we see these patients as a consult, we're thinking through the variety of risk factors that they have for poorly controlled pain. The kind of perioperative and trauma research says that if a patient has pre-existing pain state, if they have pre-existing psychosocial comorbidities, that they will have a more challenging perioperative period. Quite clearly, in this instance of this patient, their chronic daily heroin use is going to make this very challenging because they are going to be exquisitely opioid tolerant. And beyond that, we may have challenges with just their coping ability. Often patients who end up using opioids chronically have something that relates to their ability with coping with maybe a pain experience or other life stressors. And they may rely on these maladaptive patterns when under stress or in pain. So we have kind of a pharmacologic challenge, and we also have a psychosocial challenge. One of the first approaches that we utilize when we see these complex patients is making sure that we're leveraging multimodal as much as possible. So treating pain down as many different pharmacologic pathways as is possible. And we are looking at a variety of options. We look at NSAIDs or nonsteroidals. We are looking at Tylenol and appropriate dosing. We are looking at the role of a muscle relaxer. We also even get into some of the pharmacologic treatments, maybe more for chronic pain that we might use in the acute setting, like gabapentin, Lyrica, maybe even the serotonergic type medications like Cymbalta. On post-op day 0, that might not be something that we are pulling out, those latter two options, because they have a longer time frame until they start to reach efficacy. But nonetheless, when we step in, we're really thinking multimodal. But we also have to keep in mind the patients that we see at our institution, and I bet also at yours as well, are very medically complicated. And so we have to be mindful and collaborative with the ICU team. Is an NSAID appropriate in the context of this gentleman's splenectomy? How are his platelet counts? Did he have a significant blood volume lost? Does he have an AKI from hemorrhagic shock or something of the sort? And so we are working very closely with our consulting teams and surgical teams as well. We're trying to understand exactly how complicated the surgical case was and what their blood loss was like in the operating room. What were the hemodynamics that they had in the OR? As an anesthesiologist, I will sometimes pull up the anesthesia record to understand how complex their anesthetic appeared to be. Were they on pressors? Did they need large volume resuscitation? These are all things that I'm really thinking of and considering when we see these really complicated patients. And then an additional thing that we're always thinking of as an anesthesiologist, I'm always considering what tool do we have to consider regional anesthesia? If this gentleman only had a tib-fib fracture, we could discuss with our orthopedic colleagues if a regional block would be appropriate, because that would take away the the pain from the fracture. But this gentleman is polytrauma. So even if I did a regional block to cause numbness of his extremity, he was likely to still have a significant amount of pain, for example, in his rib fractures. And then we start to wonder, is it meaningful? Is it impactful to take away one of his pain experiences if the other one remains behind? And I recognize I haven't yet touched the opioid management, but that is, and we'll talk about that, that is kind of the multimodal lens that we definitely start when we see these patients as we look at them. Bill, Lisa, any other thoughts or comments on the multimodal approach? Oh, and I guess I didn't talk about infusions, but Bill or Lisa, any other thoughts there?
I think you really covered it other than the analgesic infusions that we leverage on our service. So we do offer ketamine infusions and lidocaine infusions. So very frequently for patients like this, we will nearly immediately be looking for whether that would be appropriate, kind of if there's any contraindications to one or the other, and then sort of trying to understand their upcoming surgical interventions, if there are more painful surgeries still ahead of us, is the timing, when could we leverage one of these infusions to best align with when their pain will be the most severe?
And Bill, Lisa, and I are always thinking of ways that we can make sure that the electronic health record, or EHR, is assisting with this process. And so some of that includes even our consult note kind of encourages our team members to make sure that we're addressing all of these multimodal options. So in the template for assessment and plan, it kind of highlights, what is your thought about this? What is your thought about that? So that we ensure, even if like an intern overnight is getting this consult, the way that we have set up our consult note encourages them, even when they're on their own, to make sure they're thinking of all of these pharmaceutical classes. And then very pointedly, Lisa especially has done a very good job of putting together dot phrases that we use in the Epic EHR for when we are considering these different infusion medications like lidocaine and ketamine, so that we are mindful of assessing for relative and absolute contraindications. Again, so that in the complexity of all of the matter, that something isn't missed, and so that if it's not Lisa and I at 1 PM seeing this patient, right, we're pretty well versed on this. And if it's my anesthesia resident who's very busy in the OR simultaneously managing this issue at 1 AM, that we have been mindful of leveraging our EHR to support them in this decision making as well. And so I think that's always something that we're discussing as a group through stewardship and through our inpatient pain service to make sure we minimize the likelihood that something important is missed. So that kind of addresses the multimodal approach that we use. And then, of course, this patient is still going to require some degree of opioid. And we are aware that this patient is going to be opioid tolerant. There is perioperative evidence that shows that ketamine has a significant impact, most likely in reducing the opioid requirement of a patient with acute pain or perioperative pain. The impact that it has on improving a patient's VAS, or 0 to 10 pain score, is not as significant as it is its likelihood to reduce the patient's opioid requirement. So that's why we are very often recommending that medication if a patient is opioid tolerant, like our patient is in this scenario. But of course, he is going to need some degree of opioid therapy. And there are a few different ways that we can provide opioids in our institution. So there is IV opioid, there is oral opioid, and we are very fortunate as well to have a highly concentrated oxycodone product that is available sublingual. And so we have a variety of different strategies and ways that we can give the patient these medications. IV medication can be given on an as-needed basis by the nurse. The patient can be set up with a PCA depending on the acuity of their situation. Our PCA has the ability, of course, to run continuous infusions and to have intermittent boluses. within our institution, if you are going to run a continuous dose, it does say that you should have the anesthesiology pain service involved for assessment of the patient. I would say 99% of the time when we come on board, we say that that's probably really not necessary. And so we are very infrequently running continuous infusions of opioids for our patients. I think one of the most important things that we do as a group is have really frank conversations as well with patients about pain expectations. That can be really challenging on post-op day 0, but something we can talk more meaningfully about with the patient when they're kind of out of the worst acuity of their medical scenario. Lisa, you do this quite a bit. Do you want to comment a bit on what our approach is to kind of patient coaching of the opioid tolerant patient for their pain management?
Definitely. I think that having these conversations, having them early, having them frequently are very important to having some success in these very challenging situations. So early on, I really try to um, set the expectation that unfortunately opioids probably won't work as well as we wish they would, but we will do our best. And really trying to set the tone for what the main goal is of kind of all of the medications that we're using together to help with pain, and that is to promote functional recovery. Of course, we hope that we can bring that VAS pain score down, but that is really not our most important goal. It is allowing them, and I'm very explicit in these conversations, that we're looking for them being able to participate in therapies, get up out of bed if they're allowed to do so, sit in the chair, eat a little, sleep a little, but knowing that all of this will be challenging, and kind of continuing to reiterate that as I see these patients daily. Sometimes we very often kind of rely on a combination of opioid medications by mouth, as well as some IV medications, like Dilaudid or morphine. I try to be very clear about what the patient should be using first. So relying more on the medications by mouth, which will give them more stable pain control, and then relying on IV medications for like therapies or major cares from the nurses. I think being very clear and transparent about what I think is the most appropriate use of the medications that we're recommending is really helpful for the patients, and it gives them more stable pain control when they use them as recommended. I also try to, for every medication that we're recommending or starting, try to give them a sense of how long do we think this medication will be in place. So if we're running an IV infusion like ketamine, trying to explain to them that that is kind of intended for the period of maximal pain, and will probably only continue for a few days, so that then there's less resistance when medications drop away. They understand kind of the things that are happening, and aren't, upset when medications stop. As well as, I think, the transition, if we do opt for a PCA or pain button, how long that is expected to be there, how long, before we transition to medications by mouth. Really talking with the patient about all of these changes and setting them up for success as far as knowing what the treatment is now, how they should be using these medications, and then what changes are on the horizon, and kind of what goals they'll have to meet before more changes occur.
Thanks, Lisa. We are doing that quite a bit. And I think sometimes we are not only having these conversations with the patients, but sometimes it's with the patient's loved ones. Sometimes it's the bedside nurses. Sometimes it's the consulting team. Pain is a distressing experience, and it's not only distressing to the patient, but it can also have kind of a second victim effect on those in the care team. And it can be stressful to be a care team member of a patient who's really struggling. And sometimes the pain is true postoperative nociceptive pain, and sometimes it is really just maladaptive coping. And opioids and pain medications are indicated for the former, but not for the maladaptive coping. And so our job also is we're trying to help the patient see the difference and help the teams tease those two components apart, and recognizing that opioids are intended for one and emotional support is intended for the other. And then we also are recognizing that we have a role in documentation as well. We are a little bit more savvy, we're a little more skilled at having those conversations, and as Lisa discussed, and documenting it in the chart. how, we are supporting our staff, because there are scenarios where a patient is reporting 10 out of 10 pain. We round on them and they look quite reasonable. And part of our job is kind of reflecting it in the medical documentation to support the nurses and the primary teams if they aren't escalating the opioids or aren't putting a patient on a PCA, or they aren't doing more because it's not clinically indicated, because it's there's maybe a disconnect between the patient reported scores and the clinician's subjective and objective assessment of their pain. So I would say that's another important role that we have in the system. As it relates to, Lisa mentioned, sometimes we have an overlay of both oral opioids and IV available. Bill, you have done a lot of work on kind of the system management of how these medications are available in the system, making sure it meets regulatory compliance. Do you want to talk a little bit about the work that you've done on how the PRN indications are for these different medicines and how that keeps our health system compliant? I know it's your favorite topic.
Yeah, absolutely. Thank you. So, obviously we have regulatory bodies that oversee our organization. So the Joint Commission, CMS, the state, what have you, and they all have outlined very clearly what their priorities are and what their practice standards are. And not only do we need to share with those accrediting bodies what it is that we do, we also need to demonstrate a paper trail that we're actually doing what we say we're doing. And they will actually get into the medical record, and it's called the tracer methodology, and they will review patient charts. So somebody that's been admitted through the ED, then went to interventional radiology and the OR, maybe dialysis and inpatient stay, and then back to a peri-operative setting, a PACU setting, and they will follow that chart throughout the length of that stay, and they're looking for problems. And pain management is ubiquitous. It is in every corner of our organization. Unfortunately, lots and lots of people have pain out in the community, and that proportion is arguably higher in the inpatient setting where I practice most of the time. And we really leverage clinical decision support, or CDS is what we call it. And that's really how we optimize elements of the medical record to make sure that in short, it's easy to do the right thing and it's hard to do the wrong thing. So I tell my prescribers and my pharmacist colleagues that if they're trying to put something into the medical record and they're having a real hard time figuring out, and they tried a couple of workarounds and they couldn't get it in, and they ask me for help, my response is usually, we designed it that way. That's something we don't want you to do. That's why it's so hard to do. The path of least resistance should be the most logical treatment that addresses the needs for most of the patients most of the time. So we've worked real hard to create structures where providers are appropriately ordering PRN medications for appropriate levels of pain. We've made the default functions and options in order entry logical and transparent, and we try to have the defaults match the environment. So the default that you might get for a dose in the emergency department is going to be maybe a little bit more aggressive than what you're going to get on a post-surgical floor or a medicine floor. The compliance with nurses administering the meds on exactly how they're prescribed by the prescriber is also very important. So we want to make sure that there's an easy way for the nurse at the bedside to not only assess pain and to document pain, but to ensure that the information about what pain meds are available is easy for them to find. It's quick for them to find. We want to make sure that there aren't gaps in care. So for example, we would not want a situation where a post-operative patient has an oxycodone order, let's say, for example, for moderate pain, but then they don't have any order for severe pain, because what's going to happen? Well, the nurse is going to give the oxycodone, but technically speaking, it was ordered for moderate pain, and based on the pain score that the patient reported and the nurse charted, they actually have severe pain. Well, that would be an example of noncompliance. And we really need to make sure that, again, the exchange of information and where information is available and visible is in the right place at the right time for the right person to use that information appropriately. So we lean heavily on using the medical record in a thoughtful way to, again, make it easy to do the right thing and hard to do the wrong thing. We also have a number of practice guidelines that exist. This can be for disease state management, more broadly, like opioid use disorder, or it could be very narrowly focused, like lidocaine infusions for pain management, for example, I think is an example that was brought up earlier. Pain Stewardship owns the writing and oversight of all of the pain-related practice guidelines that are at our organization. And I can tell you that a practice guideline that is written with multidisciplinary team is going to be better than when it's done unilaterally. So for example, Dr. Kirchen with an anesthesia background had some concerns about lidocaine that might differ than what I prioritize as a pharmacist when it comes to side effect profile, based on our training, based on our experiences, based on the cohorts of patients that we care for. Lisa is the backbone. She's the constant on the inpatient pain service. She's there every day. I'm only there 2 half days a week, and Dr. Kirchen is there for a full week at a time, but probably every 4, 5, 6 weeks, whatever it is, right? So Lisa is tasked with managing the day-to-day operations of the team with multiple levels of learners. She's got med students, she has medical residents, she has fellows, she has surgical fellows, she has rehab fellows, she has pharmacy students and pharmacy residents. There's a whole host of learners, and the significance of that is that they all have different levels of expertise. So we need to have some sort of standard of care or practice guideline that everybody can refer to so that we're all on the same page. Dr. Kirchen and Lisa both emphasized the importance of clear communication with the patient and between teams. That's also important when different team members are facing the patient. We need to make sure that we're sending a consistent message, because not any one of us are here 24/7. So we need to make sure that there's standards in place. Having a practice guideline that establishes practice standards is a very easy way to do that. The feedback that we're going to get from Lisa is going to be a little bit different than the feedback we're going to get from a surgery resident or an anesthesia fellow, right? Because she's managing the team on a day-to-day basis. And she also spent a number of years at the bedside practicing as a nurse before she transitions to this role. She also understands what the nurses are going to be thinking. How are they going to read this document and interpret it? Is there any language that might trip them up? We also know that lidocaine is a medication that requires serum drug levels to be drawn. We rely completely on the nursing staff for that. So again, we need to be clear in our communication. Clinically, Dr. Kirchen might have something in mind. Regulatory-wise, I might have something in mind. Operationally, Lisa might have another priority in mind. It's the intersection of all those minds coming together to make sure that a practice guide, whether it's focused on lidocaine or PRN pain medication administration, is sending a consistent message. It can be a resource, a tool for everyone on the team to use to make sure that we're all speaking the same language at the same time. With an organization this large, it can be a challenge to get everybody on the same page. So really ensuring that our process of developing practice guidelines, our process of establishing practice standards, our process of implementing clinical decision support within the medical record is robust. If that process is robust and it's multidisciplinary, and we pull in all stakeholders, not only the content experts like a Dr. Kirchner or Lisa that are driving it, but also the end users, the bedside nurse, the PM&R resident that's floating through call by themselves overnight for the first time in July. We need to make sure that they all have the resources. And if the process included a multidisciplinary group of stakeholders, we're fairly confident that that document that will be used as a source of reference will get us all on kind of the same page. Hopefully that answers your question, Dr. Kirchen.
That and more. Thank you, Bill. That's great. The last target that I do want to make sure we cover, and then I would like to give people time for comments and questions and conversation of the group that we have here, is how would you prepare this gentleman for discharge? So let's say he's through the acuity of his experience. My approach is that even patients with opioid use disorder, if they have a pain state that warrants opioids, that they should be prescribed opioids as they prepare to discharge, so that their pain is appropriately treated. Again, with clear communication with the patient about expectations, how long this opioid therapy is reasonable given your injury, how you will wean off of these medications, and then for risk mitigation, we'll discharge these patients with a prescription for naloxone. Now, if we want to talk multidisciplinary, this is a time when during their hospital stay, we will also engage psychiatry so that our addiction team can speak with the patient about if they would have interest in medications for their opioid use disorder. And so at our institution, they will offer the patient methadone or buprenorphine. And the utilization of buprenorphine and inductions to buprenorphine at our institution have been growing over the last few years. Lisa, now recognizing neither you nor I are addiction type, we don't run it technically an addiction service. It is not our subspecialty. What has been your clinical experience of what you've seen psychiatry do? At times we'll do microinductions or different transitions. What have you seen done?
So I would say the most common method that I have seen done is microinductions of buprenorphine for these patients, and I've seen great success with this approach. Um, all of the patients that I see have acute painful pathology that typically does warrant concomitant opioid therapy for pain. So many of the patients who I see have some exposure to buprenorphine products like Suboxone as outpatients before they ever entered the hospital. And many of them have experienced precipitated withdrawal with Suboxone and are very afraid of it. And that's a big barrier to treatment for opioid use disorder. So I spend a lot of time explaining the process of a microinduction, even though I'm not in addiction medicine, but we overlap sometimes. So just explaining to them that, well, we start at very low doses of the buprenorphine and then gradually increase to doses that would be more therapeutic for their use disorder, thus avoiding precipitated withdrawal and allowing them to continue PRN, full agonist opioid treatment for their acute painful pathology. So oftentimes we get a lot more buy-in from them with these treatment options, knowing that they'll be able to continue to have medications available for their acute pain. We are very lucky to have a social worker on the addiction side of things who I work with quite closely, and she'll help the patient with all the kind of logistical issues of getting them set up with a clinic to follow at for use disorder upon discharge, helping them, they, I think, usually provide them with a prescription for the Suboxone or methadone before they leave, and just making sure that all of those details are hammered out so that they actually have a much greater likelihood of being able to follow up. As I was saying, buprenorphine is really the most common agent that I see. We do see there has been a little uptick in methadone recently, I would say. And so something that not as familiar with that for use disorder dosing, but I am seeing it more where they'll induce them and then fairly rapidly titrate up the doses before they leave. I would say a challenge with methadone, in my experience, has been that it just takes longer to titrate, longer than the buprenorphine microinductions. And so oftentimes the patient may be medically ready to go, but the methadone may be a barrier there. So all of these conversations I initiate very early. I actually saw a patient this morning who kind of fits this same sort of scenario like we're talking about, and they came in yesterday night, and I'm recommending that our addiction team come and see them today. So the sooner these conversations can occur, and it doesn't have to be initiated now, but the sooner the better, so that it's something that's at the forefront of everyone's mind and it's not something that's being left until just before they leave. I find a lot more successful, and I find the patients do a lot better once they have some treatment for their use disorder on board as well, so that they're not both in acute pain and also acutely withdrawing from opiates as well.
That's a great clinical summary. Thanks, Lisa. Bill, do you want to share anything that you've had from a stewardship point of view of what it has been like to get greater access to buprenorphine in the system, getting more inductions to buprenorphine in the ER and in the inpatient setting? Just because I know that's been a really impressive project here.
Yeah, we've definitely had some wins. I would say 6 years ago when we first started this process, we did not have a process for induction of methadone or buprenorphine in the inpatient setting, and that was really challenging. Psychiatry was available, but they didn't have infrastructure to support them, so they really only were inducing 1 or 2 patients per month. Again, bringing a multidisciplinary team together and stakeholders together, we were able to identify who needed to be at the table to operationalize this process. So it came down to psychiatry and pain management, physicians, nurses, pharmacists. We had to pull in our local DEA agent to help us interpret some of the regulatory standards. We had to pull in risk management and corporate compliance, again, being the orchestrator of all of this. Again, the steward not having the contents expert of all these different areas, but having the vision of who needs to be at the table to provide input. And as a result of that, as an organization, over the last 3 to 5 years, we went from having about 50 chronic buprenorphine patients throughout our organization to having about 400 chronic buprenorphine patients being treated for opioid use disorder. Now, what is the significance of that? Well, we know that having patients on those medications improves the quality of their life and it decreases mortality. So that's a patient-centric outcome. What does it mean for our staff? Well, it means that more frequently, we're seeing patients coming into the inpatient setting from the community that are on buprenorphine. And buprenorphine, for the pharmacists out there, it's kind of a wonky drug. It's a partial mu-opioid agonist. It's got some atypical pharmacologic properties. It complicates acute pain management because of how it binds to receptors. There's a lot of nuances for managing acute pain in patients on high-dose chronic buprenorphine for opioid use disorder. So once we started treating patients with buprenorphine, then we needed to roll out a whole bunch of education about how to manage acute pain in the setting of chronic buprenorphine. Again, a multidisciplinary effort. We also needed to facilitate education in the ambulatory environment to make sure that the primary care providers and the specialty providers knew how to manage this patient in the ambulatory setting as well, and what sort of drug interactions might exist and other complicating factors like that. We have had recently cases where patients who use IV drugs are prone to bacteremias and sometimes infective endocarditis. Sometimes those can be fungal in nature. You can have limb-threatening infections that can be fungal in nature. Some of the more potent antifungals, especially the azole drug class, has really, really nasty drug interactions mediated through liver metabolic enzymes, the cytochrome P450 pathway, with different opioids. And really, you got to bring the team together to figure out how to manage these patients. So, we even see infectious disease consult service communicating with the inpatient pain service to try to kind of work through some of these more complicated opioid use disorder patients. Methadone is an entirely different drug with an entirely different set of circumstances to consider. When I teach my pharmacy students and pharmacy residents about drug interactions, I say, you got different tiers of drug interactions, and some of them you're going to have alert fatigue because the system all day long, the electronic health record is giving you alerts, caution, trying to slow you down, and there's a lot of static there. Frankly, there is a lot of static, but there's a handful of drugs on a short list that when you see a drug interaction potential with one of these drugs, you really do need to slow down and pause. And on my short list, the very top of my short list is methadone. A little bit further down is buprenorphine. This falls in the class of other drugs like digoxin, warfarin, Flagyl, ciprofloxacin, theophylline, other kind of scary drugs that can cause lots and lots of nasty interactions if not managed properly. So, while we've improved patient care, we've also increased the level of complexity of the patient care during the ambulatory and inpatient visits. And as a result, again, we brought multidisciplinary teams together to develop practice guidelines. So the resident that is 1 year out of med school or the physician that has 20 years of practice can all refer to that document that has stakeholder input from all the disciplines to make sure that we're all speaking the same language, we're all following the standards of care.
Yeah, thank you.
Okay, Dr. I just wanted to know this case, the patient has been hospitalized how many days?
In this case, how long will they be? They may be
Yeah, you
hospitalized.
already in the hospital because you are going to discharge him.
Yeah.
And how many days he has been in hospital?
I would say typically a patient like this might be in the hospital for about a week is probably a typical duration. Lisa, does that seem appropriate? Sometimes it depends on their weight bearing, how they're progressing with PT, what is the discharge plan? Will they go to a rehab? Will they go home? Are they meeting their goals? Some 30-year-olds jump up and recover.
My major work before was doing the trauma team to the post-injury rehab. I found it's quite different at multiple trauma rehab.
Uh-huh.
I found this brain injury rehab patient has quite different prognosis for pain-wise, for pain control-wise, than the multiple trauma. The reason is during brain injury rehab, patient is a minimal mental status for a relative long time, for example, 1 week or 2 weeks. During minimal mental status, patients usually do not need any opioids. So in this kind of patient, after patient recovered from brain injury, the patient's pain management is much easier. That's the kind of experience that reminded me during our inpatient rehab or during acute pain management, we should not only give patients opioids. We need to start our combined treatment.